I hope everybody had a good lunch now that we have food versus brain disease. I hope you can stay awake and listen. Gracias a todos por invitarme. Es un gran honor estar aquí. Y yo he conocido a muchos de ustedes en mi visita en diciembre y eso es el fin de mi hablar en español. So today we're going to talk about transplant and we're going to talk about chronic and acute graft versus host disease. And it's going to be a high-level whirlwind tour, and I hope that we can get through all of this together. It's going to be one talk with all of it together, even though the itinerary says two separate talks. We'll go over T cells and why they're important. We will go over what acute and chronic graft versus host looks like, and some of the prior speakers have already set the stage for this. We'll talk about ways to prevent and treat it, and looking towards the future of graft versus host disease. If we remember back from medical school, T cells can be attacked or attack. And so if the host T cell attacks, goes towards the patient's body, you have graft rejection. So if it goes towards the stem cells, you're going to lose your graft and graft failure. But in the other direction, if the donor T cell attacks host tissues, that's graft versus host disease. So the same process in different directions. And again, as you know, when we're looking at a match between a patient and a donor, we're looking at the HLA antigens on chromosome 6 to see if they recognize each other or they find themselves to be foreign. And this is very important for not only graft versus host disease or developing tolerance, but also the ability to recognize antigens as self, which affects immune reconstitution and infection overall. As you know and have heard, graft versus host disease is this histoincompatibility between the donor and the host. And what happens thereafter is not only is it an incompatibility, it sets up a fight between the patient tissues and inflammation processes. And so you have an ongoing level of fighting between your body and the donor cells. In a malignancy, this can be beneficial, and we take advantage of that. I am trying to speak a little slower than normal so that I can help my friends in the booth over there. So why should we care about graft versus host disease? Well, there are direct implications of graft versus host disease. Oh, wow, this is interesting. I don't know how to use that. But anyway, you can see here looking at the probability of having graft versus host disease is directly correlated with the amount of mismatch that you have. And the more mismatches you have, the more acute graft versus host you're going to have. And this also correlates with mortality. Okay. Also correlates with mortality. You can see here was a study looking at patients transplanted for AML. You can see that patients who had no graft versus host disease as opposed to active graft versus host disease had a much more likelihood of surviving. People with active graft versus host disease had 1.6 times likelihood of dying related to any cause. If you are comparing death not related to a relapse, that risk went up to 3.24 times. So graft versus host disease does not help when you're talking about survival. It's really important to step back to medical school and look at what are the T cells we're talking about, because not all of them are the same. First, we have CD8 T cells that can be naive or memory. And if you remember that CD8 T cells are those that create cytotoxic T cells and are really what recognize sort of our pathogens they're on all nucleated cells, just so you know, and they lead to uncontrolled sort of expansion and attack of foreign proteins. CD4 cells come in different flavors, including Th1, 2, 17, and Tregs. Those are the four that are very important. Th1 are the cells that control and contribute intracellular and autoimmune attack. Th2 are the ones that help with extracellular control and often in dysregulated states lead to an allergic response. Th17 are very important. They've been discovered to help with pro-inflammatory activity. And Tregs, the last one here, are the ones that actually induce tolerance. So it is likely that Tregs play a very big role in graft versus host disease because in their absence, you have way higher amounts of graft versus host. And we'll come back to that. Again, looking at CD8 T cells, you start with what's a naive T cell. It gets committed to a more differentiated cell. Those are the effector memory cells. And then once they are different, they see an antigen and respond, they become terminally differentiated. So this is our set of cells that's ready to go, ready to respond to certain things. Again, the more mature and differentiated T cells, the less likely they are going to attack something that they shouldn't. CD4 differentiation is shown here. Once a CD4 cell sees an antigen-presenting cell, showing it what it should respond to, the CD4 cell differentiates into one of those three varieties I described. Again, Th1 helping with intracellular pathogens, Th2 helping with extracellular pathogens, and Th17 protecting against some of those pathogens and inflammation. All of this growth and all of these responses are done because of cytokines, intracellular signals that really help us grow. Antigen presenting cells, as you know, are what bring the pathogen to the T cells and say, hey, let's respond to this. And that's very important because antigen presenting cells, if left in the graft, can be very helpful to the patient. But the old types of transplants where you got rid of everything, or what we call CD34 selection, left you none of these. So you lost all immune properties and all immune helper cells. So how do we put this all together and why does GVHD happen? You start with a transplant. You have the patient's tissues that get inflamed because of tissue damage during conditioning, whether it's chemotherapy, radiation, calcineurin inhibitors, anything. It affects all the organs. Some of the bacteria that are released as well contribute to this. You start having an upregulation of inflammatory cells. You see cytokines, TNF alpha, IL-1 secreted by the T cells that sort of also perpetuate this cycle in a negative spiral. Going this way, you see that other antigens are presented to the T cells in the donor. They're actually going to block or downregulate those helper T cells. We'll come back to that. And they're going to lead to an increase in amount of inappropriate response by Th1 and Th2 cells. So because of something we're doing, you're leading to a downstream cascade that is going to keep this cycle going. We would like to take advantage of some of these areas, like increase this, decrease these cells in the bottom, or signaling, and that is where we make our mark with preventing and treating graft versus host disease. So remember this pathway because we're going to come back to a lot of this in a little bit. You've already seen a lot of this, so we'll walk through very quickly, but there's two types of graft versus host disease delineated purely by 100 days post-transplant. You can have acute, which I think of A for acute, A for angry, very red, hot, angry organs, skin, liver, gut being the primary source. Chronic, after 100 days, much more, as Dr. Ramirez said, like an autoimmune disease, tight skin, tight joints, tight or fibrotic lungs, tight eyes, dry mucous membranes, much more sclerotic picture. But make no mistake, you can have an overlap syndrome where people walk into the clinic at day 150 and look like acute fresh graft versus host. And you treat that like acute graft versus host, not chronic. You've all seen this before, classic pictures. It's been a long time since I've seen something like this. I tell patients in our family meeting, graft versus host can be anything from a mild rash to where it looks like I took a pot of boiling water and dumped it over your head. We have not seen that in a long time, knock on wood. GI GVHD can be upper or lower or both. Upper is this persistent nausea, vomiting, early satiety. They may not eat very well at all. It's very ill-defined, and your patients may look like they're just having malnutrition problems. The lower GI GVH is much more common that we see with the cramping, with the bloody stool, with much increased diarrhea. And again, pathologic features you see are loss of normal architecture, complete crypt dropout, and then just effacement of the surfaces of the mucous membranes. GVHD of the liver is as described before. Transaminitis can be present, hyperbilirubinemia and jaundice. Remember, children can look different than adults when it comes to this. And again, there is a score that was developed mostly for adults to look at what are the features the pathologist is seeing and how contributory to an end result that this is actually GVHD. But you also see a lot of destruction of the normal sinusoids. You see a lot of inflammatory debris and deposition, and the blood vessels are also eroded. As you know, we stage it and we grade it. So you get a score for each organ system, and then you take the combination score and give a grade. It's really based on how extensive is the rash, where's the liver involvement from a bilirubin standpoint, and then what happens with diarrhea. There are many scoring systems. You use the one that you're most comfortable with. Chronic GVH is, as I mentioned, a different disease. This is more of either somebody who never got out of acute GVHD and you passed the 100-day mark, or you finished, you thought it was done, like a campfire, the fire rose, the flames, the embers smoldered out, and now the flame ignited again. And I describe that to families exactly the same way. Or the rare patient who never had graft versus host and now has chronic. We've seen that too. It is rare to have single organ like pulmonary GVH or BO, but it happens with no preceding other GVHD. Again, driven by cytokines, this is a really overreactive or alloreactive CD4 profile where the thymus is supposed to select against certain T cells, but you end up with a skewed representation, many more of the Th2 affecting tissues, including the fibroblasts and causing fibrosis, and a decrease in sort of the 17 and the other inflammatory responders, as well as decreased Tregs. Nobody knows why, but you have decrease of the Tregs, which would suggest that their presence would mitigate some of this. You can't forget the B cell population. We focus so much on T cells with GVH, we forget that B cells play a critical role as well. Too many B cells without T cells or B cells that are dysregulated will also lead to antibody deposition and worse GVHD. So chronic is more of an autoinflammatory condition, whereas acute I think of as more of what's left over, what's going on donor to host. At any point in the cancer or transplant journey, you can develop graft versus host. When you relapse, you have inflammation. When you give cells and conditioning, you have relapse and you have inflammation. Anything you do to the graft, as we talked about, and we'll get into that, can make GVH more or less likely. Again, if you relapse, you're weaning immunosuppression over time. So the presentation of acute or chronic graft versus host is mitigated directly by the things people in this room are doing. So yes, the patient's body and graft are doing some of it, but we are the other cause. Sorry, it's true. We talked about a lot of these features of graft versus host disease, so I'll move on. But remember, it can affect any organ that it wants to. And just because in pediatrics, we don't often talk about vaginal or GU GVHD, there's brain GVHD, just remember that these can be things that happen. Again, here are more pictures of chronic sclerotic GVHD. It can affect the enamel, it can affect the gums, it can affect the lungs, you name it. Again, dry, thin skin. Again, loss of crypt architecture, lots of inflammation going on in the gut. Pulmonary GVHD really, or bronchiolitis obliterans, could be its own talk. It really requires a lot of thought, and it's going to be hard to cover a lot today. But suffice it to say, it's very similar in its etiology. It just happens to be that all of the inflammation is affecting the lungs directly. You get immune activation, T cell, B cell, and host antigen presenting cells infiltrate the lungs. You quickly get deposition of macrophages, fibrocytes, and fibroblasts. You get this matrix that you get direct pulmonary fibrosis, and then you have ongoing inflammation with antibody production. How many of you have seen pulmonary GVHD? It's not a fun disease to treat. When it's responsive, it's responsive. When it's not, it is very tough. I've had 2 patients in my career, not that long, but long enough, that needed double lung transplants because of this. Bronchiolitis obliterans is the other name for pulmonary GVH, simply based on what they see. It's an obstructive picture, but you can also have a restrictive picture. So you really need good collaboration with your pulmonologist. We have developed a study where we're studying this longitudinally. We're trying to do PFTs and lab work early and often in transplant to see if we can predict who's going to get this, because you may want to mitigate these factors sooner. The other area I just want to mention about chronic GVHD that's really frustrating and annoying are that the inflammation can look different. You can get effusions, pleural effusions, pericardial effusions, which can also be TMA. Again, these are all endothelial damage processes that can look and mixed. But the long-term issues are these immune dysregulated states related to GVHD. I have had patients with myasthenia gravis out of nowhere, patients with lupus. The one that's frustrating is autoimmune hemolytic anemia. The kid looks fine, walks into clinic, they have a hemoglobin of 4. Their reticulocyte count is through the roof. They need steroids immediately. But these are the things that cause patients significant decreases in quality of life. You have all seen the scoring systems that are out there. We use the NIH consensus guidelines, but you score system by system. And I will tell you, if you want to study your patients longitudinally, it's really important to develop a system where all of your colleagues are scoring the same way and are scoring routinely. So at our institution, nobody was doing a good job. And we implemented where once a month, we were going to make sure that every patient had this. It's actually in our charts now, and now we can do studies because we can easily look back. We have a call. I think I missed it today because I'm here. Thank you for that. Excited to miss it. Where we actually run through all the patients. And if anybody knows, like, oh yes, my patient John Schmo, he developed GVH this week, we add it. So we don't want to miss anybody. And I'm being serious. I can't stand that meeting, so I'm really happy to be here. Again, lots of scoring, different scoring systems. There are pediatric specific ones, but just remember, you got to ask the right questions. If you don't ask patients, are you having trouble moving your arms above the horizon? You're never going to know. And to you, somebody sitting there like this looks like they're fine. But when I ask patients, if they can't move like this, they're locked in. Things like this are very important to at least look at this, laminate it, put it on your wall of your exam room so your mind can be like, oh, I forgot to ask about this, this, and this, because it's very easy to underscore these patients and you're not helping their therapy. Again, it's a conglomerate scoring based on, are you mild, moderate, or severe in different categories. You'll notice, as I mentioned, that if you score 1 for the lung right or anything for the lung right away, you're upgraded because the lung just moves you to a higher category. Things that often come up are, how do you diagnose graft versus host in the chronic phase? You want to make sure you're checking liver function, bilirubinemia, transaminitis, or in the worst case, fibrosis, make sure numbers normalize. You want to do pulmonary function testing as often as you can at certain time points. Often we're asked about biopsying the lung. Very tricky question, because when you do it endobronchially, you get a tiny piece of tissue, not helpful. Patients who you want to get a big chunk of tissue and do it this way, transthoracic, they're often not healthy enough to get that. So you're sort of stuck. We are often asked, should we call dermatology and get a skin biopsy? Is this GVHD? Is this something else? Not always feasible to do. And then, is this really chronic graft versus host, or is this overlap syndrome that's just presenting for the first time? I'm not going to talk a lot about prevention because we had an excellent lecture by Dr. Ramirez, but remember the major categories: match on HLA, find a way to expand your antigen matching, high resolution typing, things of that nature. Thinking about how you immunosuppress, how can you inactivate the antigen presenting cells to a degree, And can we remove the T cells that are bad? I will tell you that at our center, we are a very big center. We are very fortunate that we have the machinery to remove T cells that are selected. You're going to read about it in the literature, alpha beta T cell depletion. Those are the culprits. Europe is way smarter than all of us. They've been doing this for decades. Alpha beta T cell removal, we have gone from using calcineurin inhibitors and all these drugs that have their own toxicities to no graft versus host prophylaxis at all. And the rates of graft versus host are very small. But we are taking this a step further. We are not only depleting alpha betas, we are now often also adding back CD45 RA depleted cells, as was illustrated in a graph, to provide patients with an immune protective window until they start reconstituting their own cells. So lots of cool things coming up, but the old story goes, all the stuff we have and have been using is still there. And this is where transplant really, we need to make our mark. Remember, not all graft versus host is bad. The same principle of an immune attack against the organ systems that we don't like in graft versus host. If that attacks leukemia or lymphoma and you exploit it for its good properties, that's a good thing. I tell families, I don't need to see it to know it's happening. But this is also why a CD34 selected graft is not beneficial for a patient with a malignancy. Leaving behind something, NK cells, dendritic cells, something to facilitate presentation of a leukemic cell or something to the immune system and help eradicate it, very important. This was actually found and discovered in CML, and we've exploited it for other diseases. You're going to see a lot of the same drugs repeated because, as you know, we have an arsenal and that's all we have. And we try them in different combinations, but there are different targets and you want to use things that target different pathways. Our front line, as you know, for acute graft versus host are steroids. If you have GI gut or gut GVHD, you want to also consider adding budesonide. We call it budesonide, but intraluminal, where it's oral and you're swallowing it so that it's coating the lumen. Calcineurin inhibitors are a necessary evil. We use a lot of tacrolimus or cyclosporin. And then other ones, depending on the protocol. Sometimes for sickle cell patients, we will use sirolimus because it's a lower risk of press. And then lots of cord blood, which we don't do a lot of, but in non-malignant diseases get MMF or mycophenolate. There are sometimes we use specific prophylaxis. I already mentioned rituximab last time for our alpha beta depletion, so we don't leave the B cells unopposed. Campath, again, very selected. ATG we use a lot, especially in haplos for that added T cell depletion strategy. Again, I know you know all this, but I think the thing that and when I think about how to train trainees and talk about this, we cannot forget that it's not just the medicines. It is what are you going to do with supportive care to facilitate the improvement of that graft versus host. So when you're starting steroids for GVHD or cream, if it's grade 1 and it's just topical, start with steroid cream. Do not go to an IV or an oral steroid. You can even, if you have it, there's topical tacrolimus called Protopic in the US, and now there's topical ruxolitinib. I've never used that, but it's out there. If it's grade 2 or higher, you're going to go to glucocorticoids systemically. But remember common sense things like skin moisturizers. Tell the patients and families no perfumes, no dyes, but normal cream that's going to keep the skin moist in between steroid applications. Wet wraps, sometimes depending on how extensive it is. And also the itch. Ask your patients about the itch, because without that, you're going to be healing their skin and they're going to be at home scratching the heck out of it. So you're going to create another cycle of skin destruction. So we use a lot of diphenhydramine and other things like that. For GI GVHD, we start with IV glucocorticoids and often add the calcineurin inhibitor if they were not on it. As I mentioned, we'll also start the non-absorbable oral steroid. And our frontline go-to for GI GVH is infliximab. We do about 8 doses of this. It's once a week, and it has very good data because you're treating these patients like an inflammatory bowel syndrome patient, and that'll come back later. You want to also think about, make sure this is not an infection. So before you go scoping them and biopsying them, make sure that the diarrhea they're presenting with is actually GVH and not an infection. Think about when you're treating people for long amounts of time, they start developing malnutrition. they start developing nutritional deficiencies. So you want to check for specific deficiencies that they may have and replete them. And a lot of these patients are stuck in the hospital on parenteral nutrition. Often they cannot tolerate the NG feeds, even though I'm a big fan of it. And just so you know, there is data coming out that if you have an NG tube or you're able to get even an ounce or something through your gut all throughout transplant, you can really drop the risk of GI GVHD. So at our center, day +1, NG tube goes in the nose, and we trickle in tiny amounts of feeds all throughout transplant. And we did a study to show that that was feasible. If you have liver GVH, there is no accepted standard of care, but it's the same start, glucocorticoids, and add the calcineurin inhibitor if you didn't have it. Our go-to now, honestly, is ruxolitinib. Do you have that in Colombia? Perfect. It is the only FDA-approved drug for people over 12 that's newly approved for GVHD. We used to use antithymocyte globulin because for whatever reason, it has good penetrance in the liver and for the antigens in the liver. But because of viral reactivation, we don't really go to that anymore. But again, limit hepatotoxins. Often doing nothing or removing something is your best option. And reminding, your house staff or people that are rotating or covering your patients, please be careful when you're ordering drugs for our patient that you're not compounding the liver injury. And then again, they also need parenteral nutrition often. But again, for liver GVH, the more you can feed the gut, and enterohepatic circulation will help clear the liver out and will help improvement. Remember, the liver regenerates. It's the only organ that does that. So we can sit tight. Don't get nervous about the bilirubin number itself. I have a patient with horrific liver GVHD right now. His bilirubin peaked at 30. He's sitting in the 20s. It's the least of our worries. He'll be yellow for a while. It's okay, as long as everything else is improving. And this is from the liver team, who's an expert in this. She's stop worrying about the number. In fact, don't check it for 2 weeks, is what she told me. Not sure I can sit tight for 2 weeks, but we have different formulations of intralipids that go with TPN that are better for the liver. So something to think about as well. If you're steroid refractory, the standard definition is that by day 7 or 5, if you have no response, you are steroid refractory and you should move on to other things. And what do? You start now going down your list of things that are on your arsenal that is the same list for GVHD in the chronic phase. I will tell you ruxolitinib should be your go-to for many of these forms of GVHD. It has the most papers coming out, the most track record. I actually put a patient on this in the hospital while they were still recovering from transplant because for some reason, Matt's sibling donor, she had grade and stage 4 skin GVHD during transplant, like day 18, 19, 20. It was horrific. It was beyond engraftment syndrome. She still has terrible GVH, but ruxolitinib cooled off the skin, calmed down her gut. First patient we've ever used it that early. So think about it for multi-organ. MMF, I don't think MMF or mycophenolate adds very much to anything. If not, it gives you sort of GI upset and side effects, not benefit. If you're intolerant of tacrolimus or cyclosporin because of kidney injury or other reasons, sirolimus is okay, but has its own problems in and of itself. I don't know if you have ECP or extracorporeal photopheresis, but we have it and it's really fallen out of favor. It's very challenging for the patient. It's a very intensive schedule with very modest data. ATG, as I mentioned, but you have to watch out for viral reactivations, and basiliximab would be our go-to sort of for skin. And now Dupixent or dupilumab is our frontline, probably even more than basiliximab. But again, there is no consensus. You have to weigh all of the patient factors. You cannot pick one drug and say it's the right thing for the patient. Ruxolitinib, very high risk of CMV reactivation, so you need to be surveilling them. Remember that a reason you want to give families an expectation. Every new drug I try will only work in 1/3 of the population. Set that stage early so they don't think it's something they did or that their kid is different or special or that they're a failure, okay? It's the same thing I tell families about the NG tube. It's not a failure of your child eating that they need the NG tube. It's an expectation that they need the NG tube. And when you change that mindset for a lot of transplant, it's an easier journey to walk with the family. So again, summary for frontline acute would be steroid methylpred, usually 2 mg per kilo per day divided BID. You do this for several days, at least 7 days. If no response, you move on. If a response, see if you can start to taper. If you cannot taper after 7 days, you need to find other drugs to add. Continue budesonide or non-absorbable for gut, topical for skin. And if you're really making no headway, that's when I would consider a biopsy of specific organs. Second line, no standard of care. You can continue the steroid and the calcineurin inhibitor and make sure supportive care is good. You may be able to get somebody to an every other day steroid pattern. Don't forget hydrocortisone or physiologic replacement on those off days. But again, you're going to start bringing out your other line of therapy. Chronic GVHD therapy, very similar arsenal of things. But remember, we're not just focused on the T cells here. We're really focused on the entire milieu of the immune system. So how can we drop inflammation, slow down cytokines, tell the B cells and T cells to calm down, and really all of that to prevent fibrosis? Because if you have fibrosis in whatever organ, the recovery is slim to none. So again, similar pathway of where you start, steroids, calcineurin inhibitor, if they weren't on it. If you really have sclerosis, like very tough fibrotic skin, imatinib and PDFR modulators and JAK inhibitors, again, ruxolitinib, are very helpful for that. And then you can start to think about the targeted therapies, again, ATG as needed. Basiliximab and dupilumab or Dupixent are great for skin and don't have significant immunosuppression. I'm going to get to some of these other ones. I'm going to talk to you about what these new drugs are and a little bit about ECP later. Again, chronic, the approach is dependent on whether they're mild, moderate, or severe. This is sort of for the in general, depending, not organ specific, but continue topical for mild, continue a steroid or start a steroid with alternate immunosuppression if you're moderate. And then if you're severe, you should be moving to at least ruxolitinib. And then if you have lung, you want to think about those steroids in pulse doses like they would do for a lung transplant rejection or other major lung disorders where they give pulses weekly like lupus. Remember, the old approach to steroids was try to get to every other day steroid and calcineurin inhibitor, and you treated for almost 9 months without touching it. You would leave the patient on there. The new one is really use whatever you need to get them off steroids, because we know the side effects of steroids are the worst, and then wean the other drugs. And that's what we're really trying to do. Again, we've talked about this. So system by system, ruxolitinib can be for any system. Honestly, while there's not perfect data for the liver and the GI, it works. Dupilumab or Dupixent for skin, again, if it looks eczematous. ECP we'll get to, especially if you have major infections and you cannot tolerate any of the other drugs or you cannot tolerate more immunosuppression, think about ECP, and then we'll talk about the newer agents. Remember, supportive care for chronic GVH is even more important. Skin lotion, topical creams, physical therapy. For the mouth, hydration, making sure patients drink. You can use steroid mouthwashes. Remember, the mouth can harbor infection, so doing what you can to eliminate infection from happening. Acyclovir, antifungals, things like that. Ocular, artificial tears, hydration, steroid drops, again, directed by ophthalmology, but also sunglasses. Very simple thing that can help to take away the patient's stress when they're looking at the sun. Musculoskeletal issues, physical therapy and occupational therapy, mandatory. Patients can become locked in or don't understand why this is so important. Again, starting this in the hospital will set the stage for doing it as an outpatient. For GI, you really want to think about the infectious testing and whether or not to do an upper and lower scope if it's safe. In the chronic phases, you may need to do dilatations or mechanical dilations of strictures because that is one of the side effects. The longer GI GVHD goes on, the more your pancreas is affected and really may need enzyme replacement. So again, some of that intolerance or feeding difficulty may not be new onset upper GVH. It may be chronic and pancreatic insufficiency, something we don't often think about. And then the nutritional challenges are real. Again, GU, we don't think about in our population enough, but there can certainly be skin changes and need for some of the creams and therapies here. And then pulmonary GVH, again, it is a separate beast. Things you can do are what we call FAM therapy, fluticasone, azithromycin, and montelukast, to drop inflammation, prevent and change the microbiome just a little bit, and help the lung environment heal more easily. There are places that have pulmonary rehabilitation where you can do physical therapy for the lungs. It's not available everywhere. I just want to mention this one study called the Allo-Zithro study that came out that showed patients who were on azithro as part of the FAM therapy had less graft versus host of the lung, but a signal towards increased hematologic relapse. There are challenges with this study in that the patients were put on FAM therapy preventatively. So you cannot compare to patients who we started after the development of GVHD of the lung. So we are still using FAM therapy if they develop lung GVHD. I just want to make that clear because this study made a lot of people say we shouldn't be using this, and it actually has a lot of good data. And so it's not exactly an apples to apples comparison. Again, overlap syndrome, you're going to treat like GVHD unless they walk in your door, like chronic, unless they walk in your door and they're head to toe red and it looks totally different. But you're going to start again with topicals. You're going to continue the steroid, and you may need to go up and then adding something pretty quickly like ruxolitinib. Exciting are the newer therapies coming down the pipeline. And again, the reason they're exciting is because they're exploiting new pathways that are contributory to GVH, aside from steroids that basically just shut the immune system down and the standard things we already know. I'm going to hit some of these, but all the cell cycles. So again, we have our T cell up here, we have our B cell down here, and the interaction between the two. And some of these newer therapies are going to hit different targets. So let's talk about those. Belumosudil, or also called Rezurock, is going to shut down Th17. It binds to a protein called ROCK17, which on this graph, and the inhibitor was called KD25. It shuts down ROCK2. That is a kinase that is going to slow down Th17. If you remember, I told you that was a pro-inflammatory signal. So by shutting down Th17, it is going to slow down inflammation, and it also increases Treg activity. So you're doing two things to dampen inflammation and increase the helper cells that can help GVHD get better. It is oral, has very modest side effects, and it is approved in the United States for children over 12 if they've failed other therapies. Again, so we have used this in a couple patients. It had in one patient a very weird side effect of like skin lumps, like very tight lumps under their skin, but that was it. It didn't do much for their GVH, but it's out there. Bortezomib. Bortezomib, as you know, we use it in many disorders like ALL when necessary, but it's going to sort of affect the proteasome activity, and it's going to help down-regulate some of the cell milieu that's going to activate T cells. So it's actually going to shut down the machinery that would let T cells flourish. And it's also going to stop the antigen-presenting cells from presenting more things to the T cells. So multi-mechanism for saying, stop reacting. You're not going to see this. I'm not going to show you the antigen. It is IV. Again, very significant. It's been studied a lot. It has some neuropathy, and you need to check neuro exams before you do it. But overall, very well tolerated. And as you know, you may not know, but bortezomib is used a lot in rejection or graft versus host like diseases in solid organ transplants. So like cardiac transplants, when they're sensing rejection, which is a similar pattern, they use bortezomib. They call us to help with it. Ibrutinib is another drug, but this time it's actually focusing on the B side, the B cell side more than the T cell side. It is listed in both places, but it inhibits Bruton's tyrosine kinase. So it's a JAK type or tyrosine kinase inhibitor that's going to shut down the cell machinery and lead to B cell quantity diminishing. Therefore, you can't produce antibodies. Without antibodies, less response to stimuli in the body. It has all of these side effects listed here. They do list serious like hemorrhage, infection, atrial fibrillation, and hypertension. Again, there is not enough data in pediatrics to say if that's an adult thing or a pediatric thing. Again, it is approved in pediatrics over 12 years of age. Pentostatin, again, as you heard before, not exactly the most exciting drug. It shuts down T cell growth because it's binds ADA, and so it's a purine anti-metabolite. It's IV. It has a risk of infection, but the studies have not been like this is the most miraculous drug, but it's out there. Rituximab, you've heard a lot about for other reasons, but rituximab, because it shuts down B cells, it shuts down antibodies, and therefore it helps with the B cell side of graft versus host disease. I had one patient refractory to every therapy under the sun, didn't really have many B cells to speak about, but we did Ritux, and his GVHD finally started to come down. Unfortunately, we're left with these anecdotal stories, and you talk to your colleagues and find out what worked for them and what worked for some of their patients. And in this world of small numbers of patients, this is the best we can offer. Remember, rituximab makes them aplastic of B cells. That's the intent, but they need supplementation with intravenous immune globulin. Ruxolitinib, I've been talking about it all day. It is a JAK1 and 2 selective inhibitor. It shuts JAK STAT pathway down, which stops transcription of T cells. It therefore prevents inflammation because the T cells are not active, and it stops the T cell damage and the fibrosis from developing. It has cytopenias as its probably #1 side effect. So when you're on it, you want to be careful about graft failure. If patients have low counts, remember, they're on CMV drugs, ganciclovir or whatever, that drops their counts. They're just peri-engraftment. Their counts are not stellar. You have to be careful with the cytopenias. Sometimes we have to support them with GCSF as well. Liver dysfunction was the #2 thing, and we've seen that as well. And then obviously infections, as I mentioned, checking for CMV and other viruses. Again, this is approved, and I think it's our major go-to for GVHD. Finally, in this category, tocilizumab, as you might know, it's used for CAR T cell CRS, cytokine release syndrome, but it also dampens T cell signaling. That's why it works in CART and CRS. By blocking the IL-6 receptor, it blocks the downstream activation and energy spread of T cells. We've used this, and there's data on it for gut. So if you're out of options for gut and you're really seeing a lot and you don't want to add more immunosuppression because it's very mild to that degree, this is a good option. And then tyrosine kinase inhibitors, the old school imatinib I already mentioned, very good for fibrotic GVHD because of the pathways that it's affecting. I will tell you that you really need to think about this. We're seeing this with the CML patients, that their bone health is very significantly affected by TKIs. What else should you consider when you're thinking about graft versus host disease? You want to think about ECP. I've mentioned this several times. Do you have that available here? You do. Do you use it? Sometimes? For some refractory cases. And as people who are unfamiliar, what happens is you're connected to a machine like a dialysis machine. Your blood is taken out. Your T cells are collected. The T cells are treated with methoxysorolin. That is a chemical that when you put it under UV exposure, the T cells get killed. So it's a non-immunosuppressive way of inactivating T cells. Because think about your patient who has so many infections, I cannot add another immunosuppressive drug. This becomes a very attractive option. The problem with this, and you'll see that's the schema, the problem with this is if you look at the bottom, this is the schedule. And there's many out there, but you're supposed to do it 5 weeks, 3 times a week, 3 weeks, 1 time a week, and then you taper. You also need a central line that is big, and you need 2 of them. You have to monitor organ function. Families cannot comply with this. This is a lot to ask a family and a patient to go through. At our center, they used to have to be transported to a whole nother area. It was just a mess, and they ended up living in the hospital for a very long time. It does have some good data on skin, maybe a little gut and liver. But the key thing to know is that the overall response rate in one of the most major studies that was done is that it had a 68% overall response rate in acute graft versus host and a 69% in chronic. So nothing to snicker at, okay numbers. The only factor correlated with survival was if you could wean the steroids within 30 days because the ECP was successful. If you could do that, continuing ECP was going to be beneficial to that patient. But if no response by 30 days, they should come off ECP. Again, you can see, as I mentioned, skin, gut, and liver have the most success rates. lung, I just think that you have small numbers. You don't know exactly. Other cool new things are low dose IL-2 for GVHD. There was a study in Boston that was done with low dose IL-2 infusions with the understanding that this is going to flip the proportion of T cells from a more CD4 skewed population to more Tregs and increasing NK cells. So you're going to dampen inflammation, increase the amount of healing cells, and slow GVHD progression. The trial that I had a patient go on it, went up to Boston to do it. And I mean, this actually like happens. You can see here the skin went from terrible to amazing in 6 months. But the most telling, and the reason why all these additional therapies are critical, I mentioned, get them off steroids, right? So they measured that. Here's the steroid dose on the y-axis. Here's the baseline at 6 months and 1 year. And look at how many patients were able to come down off of their to very low steroid doses because of IL-2 infusion. I think we're going to see more and more of this happening over time. It's hard to give, it's hard to get, it's only under a trial at the present moment, but I think this is going to have a role in GVH for kids. And then mesenchymal stem cells, which you guys have, we do not, because our government is stupid, but they won't allow it. Our government is stupid for many regards, but I'll leave it at that. I think that there are, what they do is they promote, there's no HLA expression on MSCs. So you don't have to worry about a graft versus host or impaired mechanism of causing more GVH. They provide an immunoregulatory and promotion response. So they dampen cytokine release, help the proper growth factors, help the Tregs start to grow, and actually provide the basis for new tissues to grow. Again, they can help with creating apoptosis when it's appropriate. They can help the target cell by delivering the right things that it needs. And another, what they think is really important is this paracrine secretion. So the MSC will secrete the stimulus needed for this tissue to know, I need to differentiate into an oral skin cell or a regular skin cell or whatever it's supposed to do. That is what more like the gut and the liver, but that's how it works. So chronic GVHD, in summary, you should score your patients according to the NIH or other consensus guidelines and do it consistently so you can track them. If you're on a steroid, add a calcineurin inhibitor. If you're on a steroid not at the maximum dose, go up to the maximum dose or consider pulses. If you're already on all of that, there is no standard. This is when you start to want to think about ruxolitinib or organ-specific things. You want to give it about a month. So we said a week to determine steroid refractoriness in acute GVH. For chronic, you want to give it about a month to see if all of these therapies are doing anything, because some of the newer drugs take more time, but there is no standard. We talked about that. So how I approach it, I think I've already told you this. Steroids followed by calcineurin inhibitor, adding ruxolitinib where appropriate, and then I think system by system. So if they're having GI GVHD, make sure you're giving infliximab. If they've never gotten it up front, we have repeated a course later on. But honestly, if you may want to go to vedolizumab. I don't know if you have that here, but that is the new drug that's out for very early onset IBD. So a lot of our patients with inflammatory bowel disease treated in the inflammatory bowel disease clinic respond well to this, and we're starting to use it for GVHD. Budesonide is a luminal adjunct, and then tocilizumab if you're strapped. Again, we can't get all these drugs for all these patients. Sometimes insurance says no, or they're just not available, or they're too little and we have no data. Dupilumab, honestly, is excellent, or Dupixent for skin, as well as imatinib if it's sclerotic. And then I cannot say enough about doing physical therapy, hardcore physical therapy, not like a 10 minutes. Like you may need to admit them to a rehab center for those kids who have that unfortunate, they're locked in, they're wheelchair bound, things like that. And then for the absolute refractory cases, we try everything under the sun. Rezurock, ibrutinib, ECP rarely. But I think we can do better. And someone alluded to this already. We should be able to predict this. I should know which of my patients is going to have the worst graft versus host. Now, I do. If I give them a haplotransplant and I don't take out the T cells, well, we're kind of screwed. But if you do everything correctly, can I predict which patients are going to have the worst outcomes? And so there are new biomarker panels that are looking at this. There are biomarker panels looking at ST2 and Reg3A. They are more predictive than the steroid response that I just described. It does differentiate between the overlap syndrome. So that's important to know, because I had the same question of, you really going to tell me this is GVHD and not TMA? It can. These are very specific to the gut, but they're also seeing elevations in these markers in skin and other types of GVHD. And you can look, the data speaks for itself. If you have high-risk biomarkers, so if these come in a high-risk pattern, you have a much higher chance of dying, not from relapse. Whereas if you have low-risk biomarkers, you have a much lower risk of dying. You can now send these tests commercially. The vendor we use is Eurofin's Viracor, and usually get them within 72 hours. This was developed in a study called MAGIC. It's a consortium that did all this work. And there is a new trial coming out that's aiming to see if we can predict those patients by sending this test basically weekly, before transplant, during transplant, after transplant, and follow their markers. And if they start creeping up, you're going to initiate GVHD therapy sooner and follow their markers as it gets down and wean your steroids. The patients who are not low risk and are really high risk, you're going to keep them and treat them appropriately. But this is really trying to say who's low risk, who's going to do okay, and who can I get them off the toxic drugs faster. So we're excited to be part of this study. So the future is really addressing the actors that influence the emergence of GVHD. So this is like the diagram I showed you at the beginning, but there's other things we can do aside from new drugs. So thinking about very beginning, are you going to T-cell deplete or not? How are you going to control the T-cell populations, whether it's with ATG, post-transplant Cy, alpha-beta T-cell depletion? Can we use an additional thing to modify the effector cells? So can I add IL-2 as I just described? Can I somehow increase the Treg component during transplant? Reduce the effector cells that are going to cause problems? Can I reduce the naive cells? Remember, it's the naive cells that cause more problems. So if I can do that, would be great. And that's where you get into here, figuring out what's going to be in your graft, what's going to be left behind, and what you're going to take out. Can I do something that's going to enhance B cell function, that's going to therefore impact T cells? And can I do anything to actually make the thymus smarter so that when the new cells reconstitute and go through the thymus, they don't cause these problems? I don't think we're there yet. There was a study in Boston also for thymic transplant for these patients. You have to do a lot of things to become eligible, and most patients are not eligible. If we can change the conditioning, go to a more reduced intensity or reduced toxicity conditioning, make the damage to the body less, better anti-infectives, less infection, you're going to see less alloreactivity. So we need to work on this section a lot. We need to prevent fibrosis sort of by all of these secondary insults. We need to work on better wound healing, decreasing profibrotic T cells, and all of the tissue damage. This is a huge chunk and no small undertaking. So finally, if we can do all that and prevent relapse, because relapse in and of itself is a GVHD trigger, and integrate the biomarkers, we may be better at dropping the risk, knowing who's at risk and what you might do different for that patient, right? If they're a very high risk of graft versus host, you might think twice about using unmodified bone marrow, or you might think very strongly about adding ATG or doing something in addition. So that would help you. And then if we can figure out how to drop the insults, would be great. We talk a lot about late effects of treatment itself. I want to just recall and tell you that the side effects of GVHD therapy in and of themselves are terrible. So ECP has its own issues. The steroids have a whole bat of issues. Calcineurin inhibitors have a whole ton of issues. Immune ablation has its own issues. So again, we're focusing on treatment and getting them to survive or through their immunodeficiency or whatever. But don't forget that every time we pick a drug or a therapy for GVH, you are also causing a problem. So think about this just like you would other late effects. And you often have to explain this to families like, I'm stuck. And this is why I put this here. We're balancing everything. I need to do something to help you. But at the end of all this, you may end up with a totally different disease, and it's called graft versus host, though you're cured of your leukemia or whatever I set out to do. And that's a really tough pill to swallow. But having these open and honest conversations is very important with your patients and families. Again, long-term survival from transplant and GVHD is absolutely critical. Once you start getting into problems, we're very good at, oh, has lung issues, go see a pulmonologist. Has skin issues, go see a dermatologist. But we should be proactive and doing that more routinely. Simple things like antifungal use, voriconazole. I don't know if you've seen the recent study. 25% of patients who had a transplant and had voriconazole have skin cancer. So all of these things we're doing to prevent infection also cause problems. So nothing is free. It's all important for us to keep in the front of our mind. So I love this cartoon. It's a stem cell telling its child, you can be anything you want when you grow up. And I really thank you so much for having me. I hope this was a whirlwind tour of Graft versus Host. And I want to just remind you, we are colleagues, we are friends, we are available. You can email us. I can bring it back to my team, and we're happy to discuss very challenging cases. We've done this with Center in Medellin and other places. I also offer a virtual transplant education seminar series. I know some people try to join. We'll fix the technology. But if you're interested in getting the emails about, it's about a monthly seminar, something topic related to transplant, we're happy to have you do that. They're on Wednesdays afternoon. But thank you so much for inviting me, and I couldn't be happier for you to start this program.